going on, everybody? Welcome back to yet another episode of the Core Consults RX podcast. It's episode 218, gentlemen. So
218?
We're well on our way to 300 already.
Almost there.
We're starting early.
We're starting the countdown again. You look very comfortable today.
Oh, thanks, man. I put this hoodie on because it's cold again.
It is, you know. We had the green up of the grass, and every time we do, I know there's one more frost coming to kill it.
Yeah.
It happens every year. It's really depressing.
It's a really
and I got a message today. It was like frost warning tonight at 3 a.m.
It's like, be aware that things are going to freeze. And I'm like, it's almost April now.
I know. Ridiculous.
It was like, 87 last week?
Yeah. It was great. We went to the beach.
Yeah. It's crazy. Just the dumbest state of all time to live in, just according to the weather.
False spring.
Yeah, for sure. AJ, what's up, man?
I'm cold and hot at the same time.
Well, that might be a thyroid condition. We'll have to. Yeah, we're gonna have to get that checked out, dude.
It's your spring break, right?
It is.
Nice.
The last one ever.
Hanging out with us on spring break, man.
It is,
I like it.
You will never have a spring break again.
You guys think I should be professional and turn my ringer off, or should I just leave the text messages on?
I'm sure people appreciate the dinging and the buzzing throughout the episode.
That's it. Yeah, is that bittersweet to be kind of on your last spring break? I'm sure you'll find a way to have a spring break. Don't get me wrong, but technically, your last spring break.
Spring break is a mindset.
You ready to be? And that's a bad mindset. If you ask me.
I have a spring break while I'm at work. It's not the best way to do it. It's a really unproductive week. Like, come on, it's spring break.
Spring break, man. I haven't got anything done, but you don't have to fire me.
If anyone in my job is listening, that was a joke.
Yeah, for sure. I've seen him work right through spring break. AJ, you getting ready for rotations?
I'm ready to rock and roll. I've got them all stacked up in the beginning, no breaks, all gas. Just ready to get into it.
You're starting off out of town, right?
Yeah, I'm starting off in Oahu, Hawaii. I'm going to be out there at the Queens Medical Center for a month.
Pretty cool.
I'm coming back and rounding with cardiothoracic surgeons on the cardiac ICU in Charlotte.
Man, that's a heck of a one to come back to.
I provide no useful information to them at all. Nothing that they don't already know.
Yeah, could you imagine? Oh, I'd like to share something that I think about this situation. They're like, just everyone looks at you. Please shut up.
They're not as they're my brother's in thoracic surgery. It's not.
Is he? I didn't know that.
Yeah, it's his first job out of school.
Really? Oh, that's a heck of a field to jump into.
I know.
Well, tonight we're going to be doing yet another accredited episode. So for those of you who are members of freece.com and you have an unlimited membership, or on the new platform, the gold and platinum memberships, then you will have access to any of our episodes that are accredited to get 1 hour each of continuing education for pharmacists and nurses. So if you are a member, after you listen to this episode, at some point we have to give you a secret password that will be embedded in this episode somewhere, and you will use that password to unlock the post-activity test on FreeCE's website, and then from there, you pass that, you get your 1 hour credit. If you are not a member of FreeCE, I definitely encourage you to check out all of their different learning opportunities. They have a lot of really good stuff on their website, and so big thanks to them for continuing to partner with us. So, what are we talking about tonight, boys?
We're talking about IBS.
IBS.
Irritable Bowel Syndrome. I think we've done an accredited episode on Crohn's, probably.
I think we did ulcerative colitis and Crohn's, maybe.
Probably did both, but we have not done one
on IBS.
On IBS, I was going to say
IBD, we did
with
both of those.
With the password. We should just make it fun and do like a word scramble sometime. Just give them like six letters.
It just doesn't make any sense.
And just have them figure it out.
People would be so mad.
It's contextually based. So I'm sure they can figure it out.
The odds of us getting the correct password, though, after we said random letters in the podcast to get them to upload it to FreeCE.
To FreeCE for them to upload.
0% chance.
We'd be like, dang it, we can't decipher our own words.
Yeah, we have to listen to the whole episode to try and find out. We can't remember when we put the code.
Yes.
IBS.
I digress. We're talking about IBS. So we're just going to do an overview. There is an updated guideline from 2022. Mike had mentioned that a while ago, years ago, technically, when we probably last talked about this, there was an older guideline from a different institution. The one we're referencing today is the American Gastroenterological Association, right? AGA.
Yeah, AGA. I think the American College of Gastroenterology was the one we did last time from 2020.
These acronyms can get confusing.
I know. AGA and ACG.
Yeah.
So the ACG, we'll still mention some of the, and we'll go obviously through and compare and contrast because there are some differences.
Yeah.
But we'll touch on both of those.
Yeah. So starting from the beginning, what is IBS? It's a group of functional bowel disorders. with abdominal discomfort or pain. It's usually associated with defecation or a change in bowel habits. Generally, it's more likely to occur in women and also in younger people. So about 50% of people with IBS report symptoms beginning before the age of 35. The development of symptoms in people older than 40 doesn't mean it's not IBS, but it might prompt you to look for an underlying organic etiology, like you might need to do a colonoscopy or something to rule out more serious issues.
Mm-hmm. So some symptoms, like Cole said, you can expect altered bowel habits. This can present in a few different ways. Sometimes patients will have postprandial urgency, can be fairly common. They also may have an alternation between constipation and diarrhea in some cases, or a lot of times it's more, the symptoms are more concentrated, either constipation or diarrhea, but there is, mixed IBS. Abdominal pain is actually one of the criteria now as far as the diagnosis goes. So it's usually, diffuse pain in the abdominal region, the common sites that we would expect, lower abdomen, specifically the left lower quadrant's the most common area that we have that pain is reported at, but abdominal pain is part of the main symptom that people complain about. And then abdominal bloating and distension is also another, thing that we can look to treat in patients, even if we've resolved some of their symptoms. That abdominal bloating may lead us down a path of some of the augmentation options for treatment. And then some other issues that can kind of present is this, as IBS or other conditions obviously as well, but dyspepsia, nausea, vomiting can all be present as well.
They can be. But if it isn't some of those things and it's not necessarily consistent with classic IBS, it might prompt you to look a little closer to see if there's any other more significant issues or just something different going on. So if it starts at an age above 35, onset at middle to older age, it might be warrant looking into it a little more, like we said. Acute symptoms, because irritable bowel syndrome is defined by chronicity kind of over the long term. If the symptoms are progressive and seemingly worsening over time, that might warrant a closer look. Symptoms at night, anorexia or weight loss, fever, blood in the stool or rectal bleeding, painless diarrhea, and gluten intolerance. Have you ever had painless diarrhea?
Never.
That's actually a very good question.
Let's just go around the room.
Yeah, if everyone could just give their personal experience with the situation.
I thought that was a very interesting symptom to look further into.
I guess, you
had diarrhea. Did it hurt?
Probably. I feel like that's actually, painless diarrhea is probably pretty common. I think it's like when they say pain, they're talking about
because IBS is so significantly associated with pain.
Right.
To say no,
if you're you just ate too much Taco Bell for one day, you're probably not gonna be in
or just a normal
pain.
amount of Taco Bell.
Or
if
just
you
any
ate
Taco
too
Bell.
much Taco Bell, you're probably gonna be in pain.
You might be in the ICU, but if you eat just a reasonable amount of Taco Bell, you're gonna have painless diarrhea. That's their slogan. So
diarrhea, but painless.
But painless.
Diarrhea,
that's a good one.
Diarrhea, but painless.
I cannot believe they have not asked us to speak at one of their employee conventions. If anybody knows the owner of Taco Bell, let them know. All right. So the Rome 4 criteria is how we can diagnose someone with IBS. So the Rome 4 criteria says that patients have had a recurrent abdominal pain on average at least 1 day per week during the previous 3 months, and it has to be associated with 2 or more of the following: either related to defecation, so it can be increased or unchanged by defecation, so as far as the pain goes, and then associated with a change in stool frequency and associated with a change in stool form or appearance. The appearance is going to be very key throughout this episode.
Turns out it is.
Ish.
I don't know if we have all the descriptions like we did the one time we talked about it a few years ago. But were you done with that last section?
Well, I will say too that, once you have established IBS, you do kind of want to figure out where their symptoms predominantly lie. So you can kind of use a subcategory of IBS as well. So if it's IBS with constipation, obviously abnormal bowel movements usually associated with constipation. IBS with diarrhea is going to be obviously the opposite of that. And then mixed is where they're kind of having both. And there's also unclassified IBS as well. But usually IBS C, IBS D are the 2 most common ones that you'll run into, at least in my non-GI experience.
You might ask yourself, but wait a second, we have IBS-C, we have IBS-D, and we have mixed, but like, where's the line? How do I determine whether it is one or the other?
If only there was a picture of some kind.
If only there was a picture with a graph.
AJ, show my screen, will you?
Oh, we were going to show it?
Yeah, why not?
Okay, so for those who can see, we have images of stool, but it is instilled.
It's fake stool, by the way.
It's fake stool, but it is instilled into a nice graph. So basically, you can stratify whether it's IBS-C or IBS-D or mixed based on the amount and type of stool that they're having. So if, for example, 25% of the stools are hard or lumpy, then we would consider that IBS-C. If greater than 25% of the stools are loose or watery, we would consider that IBS-D. But if it's kind of a mixture of the both,
you guessed it,
IBS mixed. If it's less than 25% of either one, it doesn't hit that threshold, but we still meets the other classifications for IBS, we'd call that IBS uncategorized.
Or person eats too much Taco Bell.
Or just enough.
So, yes, that interesting graph. Now I know for sure that we have done this topic before.
Because it sounds very familiar.
Well, in this graph, I'm pretty sure we made a joke about.
We did, and we
looking
had
like chicken nuggets.
I recall that we had another slide with the Bristol types. So the Bristol types are descriptions of the types of stool. There's types 1 through 7. The lower types are related to hard or lumpy stools. The higher types are related to loose or watery stools. But they have a description like pebbles and all these kinds of things. I can't remember all of them. We won't go through them, but I do recall.
Bristol, I imagine, is a person. And can you imagine that your legacy, you've named 7 types of stool shapes.
We've never
the
seen
morphology of stool is my life's work.
We've never seen anyone with such a wide variety of stools.
Yeah.
So we're going to name these categories after
1
you.
through 7. Yeah, and Bristol did every one of them by himself.
Surely it wasn't the person who came up with the names. It was the person who had the types of stool.
I feel like what they did is they were bullying Mr. Bristol.
They were.
I say Mr. I don't know who.
It could be Mrs. Bristol.
It could be. It could be a group of people. Maybe it was a family. I don't know. But
it was the Bristols.
AJ, will you Google that for me? He had to have done other stuff.
There were 7 Bristols, each with their own individual poop type.
Right. Exactly.
And that's what
they compiled their research, and now they have this. But so yeah, that's definitely an interesting, I guess, research project to have published. Hey, we're talking about them, and they're not talking about us. So.
We didn't address this before the episode, but we should have presumed an episode about poop was going to go off the rails. And
yeah, that's because hey, we haven't matured much since the beginning of these podcasts. So we're trying. We'll work on it.
We both have children, but we're still.
Yeah, that's my excuse to stay a kid.
There you go.
Not the fact that I'm just really immature. All right, so there was a couple things, and these are kind of tidbits that we had mentioned in the previous episode of where we covered IBS a couple of years ago. But in 2020, when those guidelines came out from the American College of Gastroenterology, there are a couple updates that they had for lab testing. They did say patients, and it was kind of their recommendations were centered around patients who have IBS with diarrhea specifically. And they said to do serologic testing can be performed to rule out celiac disease if there's other things that would kind of lead you down or potentially lead you down that differential diagnosis. And then with IBS with diarrhea, again, the fecal calprotectin or the fecal lactoferrin and C-reactive protein should be checked even in the absence of alarm features. So those were 2 recommendations that they said you can do as far as lab testing goes. And then they did recommend against routine stool testing looking for enteric pathogens. They recommended against colonoscopy in patients younger than 45 that don't have any warning signs that would indicate they needed a colonoscopy. And they also recommend against routine food allergy screening, unless, that's obviously there's more evidence that that's probably what's going on, but they don't say just to go looking for random food allergies. Also, check out our food allergy episode.
We did do one.
Food allergy and intolerance. I'm remembering all kinds of stuff we've done.
We did the whole episode on that.
I know. I don't know how we did that.
Next, we're going to talk about diet restrictions.
Yes, we are.
I have something I want to say. I'm going to try not to be offensive to my friends, if any of them happen to listen. But I tell you what.
I'm excited. I haven't heard Cole be offensive, I don't think.
It probably will be to some people.
Oh, boy.
I am tired.
This is where we get canceled.
I am tired of group get-togethers with food where we have to make dairy-free, gluten-free, everything-free, lactose-free.
Have you ever tried
foods.
doing it not that way and just telling them it's lactose free and testing them?
That is an interesting way to do it.
Because you'd be like, look at that, I cured your celiac disease.
That's an interesting way to do it, but I tell you what, I'm just like, I don't know. It's getting a little tiresome.
Yeah.
They're very hard to make. They're very hard to find things that
Yeah.
don't have any of these things in them.
I would go, well, I ordered stuff from Uber Eats because I didn't feel like cooking anything for this party. And if you can't eat the stuff from Uber Eats, I'm sorry, that is on you.
But I recognize that it probably causes a lot of distress to the people who have these issues.
Yeah. And that's why
Right.
I would only say that to my friends, by the way.
I've gone through
I wouldn't be mean
I've
to
gone through a
random
period of
people.
like, we thought where I had lactose intolerance and I didn't have lactose for a while and then I can have lactose again. So I don't know.
Cured it. You beat it.
But I don't know. I guess my feeling on it is generally, especially if it's a group like potluck type thing, like if you have that significant of a restriction, you should bring food that you can eat. But there shouldn't be pressure on the other people to bring food that you can eat. You know what I'm saying?
Or are you at fault for letting that pressure get to you?
I could be. Well, I don't let it, I should say, I'm not the driving force of that in my household.
I gotcha.
I'm very
I
much
see.
like, let's bring whatever we
She's
want.
like, it would be hilarious to bring whatever we want and then just eat it in front of all the people that can't. And then your wife's like, we're not doing that.
Right. It's
'cause
not,
That's ridiculous.
I'm not the one.
Right.
You know what I'm saying?
That's probably a good thing.
So this is more like a conversation that's going on in my household, and I'm just airing my dirty laundry.
Right. Yeah.
It's
on the
tiring.
podcast. It's good.
Yes.
In front of all these people. That
know,
way,
Cole,
that way it never gets back to
I
her.
felt the same thing, and turns out actually my aunt does have celiac disease. So you make that mistake one time.
But-
So it was at Thanksgiving.
But
Never
now we
again.
know for sure
Now
she
we
has
know.
it.
So
Confirmed.
I'm not discounting or judging the food intolerances, but I'm just saying in a group setting, it is tiresome for all the people to have to be sensitive to it.
I didn't believe her.
So, anyways, I gave her a ton of gluten,
Anyways,
and she got worse. And
Turns
boy,
out-
were people mad.
so I say all that to say that diet restrictions.
Yes.
There are things that you can do if you're having IBS to kind of exclude certain things from your diet to maybe establish if you have an intolerance to certain things that could make it a little bit better. So we've talked about FODMAPs before, low fermentable oligo dye and monosaccharides and polyols that can increase your propensity to having IBS type symptoms. Also, avoiding lactose and gluten can help in certain cases. I was having some significant issues when I was in like 6th and 7th grade, and the doctor was like, try going without lactose. So I went lactose free for like 3 months. Things got better. The lactate ice cream turns out really good as a child.
Really?
I wouldn't really. It's no Bluebell. But when I was a kid, I was like, Mom's giving me all the lactate I want, ice cream I want, because I can't have like milk and stuff. So it's great. And then I introduced milk again, and I was fine. So I don't know. In some cases, it might help people. Other culprit dietary foods might be wheat and rye, onions, pistachio, milk, of course, and ice cream. Apples even, maybe high in sugar, cause kind of like an osmotic diarrhea type thing if you eat too many. Watermelon, sorbitol, and mannitol containing products, kind of like I always think of those gummy bears, like if you load down those gummy bears,
Yep.
you're
in for a night.
Yeah, you're in for a night. You might as well have.
You're calling in sick that next
It's
day.
basically, you could do a bowel prep before colonoscopy, or you can
gummy
eat a bag
bears.
of gummy bears.
Or you can eat a bag of gummy bears and go into a coma.
So yes, so sometimes you might need to consider a trial of a lactose-free diet. Gluten can potentially alter bowel barrier functions in patients with IBS-D. There's evidence for non-celiac gluten sensitivities contributing to IBS, but it's conflicting.
Yeah.
So there's some that say it's legit. There's some that say it's not quite. There was a meta-analysis looking at probiotics. So that's a big topic of conversation, especially in bowel issues. So there's one meta-analysis looking at Bifidobacterium infantis, which is a common one in probiotics. You just want to make sure that's what you're seeing when you're looking at it. Showing that it might help alleviate some symptoms of IBS. This was in 2009, American Journal of Gastroenterology. The American College of Gastroenterology 2020 guidelines that we just talked about, they didn't buy it. So they recommended against the use of probiotics in IBS.
And remember, when they say recommend against, they're saying because there's no conclusive evidence.
They're not saying it's dangerous.
They're not saying that like if you do it, there's going to be harm or anything. They just can't recommend it as a guideline.
It's not strong enough.
Exactly.
Doesn't necessarily even mean it might not help you in some way.
I feel like sometimes people like hear that and they're like, oh, well, and they try to stop it from patients who are taking it. And if it's not causing any issues, then it's like,
right. And if they're fine paying for it, which they're not cheap either.
No. But yeah, I had a lady just the other day that I saw in clinic that was paying an astronomical amount for this, probiotic that she was getting from like Earth Fare or Whole Foods or something. She's like, no, the guy there, he's extremely knowledgeable, and maybe he is. But she was like singing this dude's praises, so he left a good impression. But he's like, this is the one that he said I needed.
Turns out it's just like
that guy.
It's just a cashier at Whole Foods.
He might be getting a commission off that because they are expensive.
And then I hear people talk about the refrigerated versus the non-fridge ones.
Mm-hmm.
It does make me wonder, like, how do these things live outside of the fridge? Like in this pill, how is this probiotic going to survive in that?
They're in there.
It's none of your
They're in there.
business.
Trust me.
Yeah, don't get a microscope and check, but they're in there.
None of your business.
Yeah, that's how.
Trade
Cole.
secrets.
Yeah, you're not a PhD.
How can they
understand.
freeze dry probiotics into this powder form that I can mix with applesauce? And I've got live back. You know what I'm saying? Like,
Yeah.
No, it's just not.
They live inside of like rocks for hundreds of millions of years.
So true. So I presume that they could make it through
through some applesauce,
some drying.
If you can make it through a cataclysmic event and be around still, I feel like some applesauce is not going to hold you back.
That's a good point.
But to jump into some of the treatment options, we're going to be basing a lot of this off of the 2022 AGA practice guidelines that came out that are directly like dealing with the pharmacological management of IBS. And so they have the IBS with constipation and diarrhea. They have two separate guidelines that got released at the same time. So we'll start off with constipation, and we'll kind of go through some of the different treatment options that are out there, and then we'll touch on with diarrhea as well, and then at the end we'll kind of look at the algorithm that they published and go through it. So to start things off, we'll talk about a very low quality evidence recommendation that they do include in their new updated guidelines, and that is the consideration of using osmotic laxatives such as polyethylene glycol, Miralax being the brand name, as an appropriate potential option for patients, at least with mild IBS with constipation. The dosing is still going to be 17 grams, which is just one capful of powder. If you're not familiar with Miralax, one capful of powder is 17 grams. You mix that in 4 to 8 ounces of liquid, and that can be water, juice, it can be soda, it can be coffee, tea, whatever you want. It'll dissolve, and it's supposed to be tasteless, and you're not supposed to be able to even tell by texture or anything that there's anything in there. It dissolves very quickly, and can be an effective method for getting people again with more mild symptoms, but kind of getting them more regular again. Mechanistically, it's working by causing fluid to be drawn into the bowel lumen through osmosis. So it distends the colon, increases peristalsis. The onset of action is a little bit variable depending on the patient. And so, 24 hours is kind of like on the short side versus, it could take up to 96 hours for some patients. It just kind of depends, on how they respond. But I think the important thing is to remind patients that it's not going to work like a stimulant laxative or, right away. Because I will say I've talked to patients who take one dose and they're like, nope, garbage. And now if you're taking like the bowel prep form, it's going to work a lot quicker because you're doing much higher doses. And make sure if you are using polyethylene glycol, it's not the one with all the electrolytes and stuff like that they use for the bowel preps.
Right.
You just give them a jar, the gallon container. Here, this is your new medicine. Adverse effects, and usually they're pretty mild, but can cause some abdominal cramping, diarrhea, dyspepsia, nausea, kind of all the things you don't want to happen in IBS. So again, low quality or low certainty evidence as far as that recommendation goes, but they did mention it. So there you go.
There are some things they didn't mention, but that you definitely will see over the counter and your patients will more than likely try. That, can be effective for mild constipation, but aren't really referenced as a recommendation for IBS. Bulk forming agents like Metamucil, Fibercon, Citrusel, they create a gel-like matrix in the stool. They soak up fluid and they add bulk to the stool to try to help move it on out. Don't use these if there's a fecal impaction, which you'd have bigger problems there, of course, or a GI obstruction. And these are also not going to be really fast acting, 12 to 72 hours. So just set expectations there. You see these, I don't know, you kind of see these as people kind of take them like multivitamins, just kind of like a daily thing to keep you regular sort of deal. But do take it 2 hours before or after other medications. You need to have adequate fluid intake for it to be effective, but it can also have similar side effects of gas, bloating. Rarely can cause a serious bowel obstruction. So be aware of that.
Could you imagine you're trying to just improve your IBS and instead you just give yourself a bowel obstruction with fiber?
That'd be a bad day.
I'd be so mad.
I'd be pretty upset.
I'd be like, this is the worst outcome that I could have had. I should have just kept it with constipation. I think that's every time I hear that class, I remember I can't remember which group of my PA students it was, but I made a comment about and called them bulk forming agents, and they were like, if you're making it bulkier, why would that help for constipation? Like, are you sure your slides are right? And I was like, whoa, we're not gonna have mutiny on my hands right now. I'm reading off Lexicomp as we speak. But yeah, so bulk forming agent is not recommended like Cole, or not mentioned like Cole said, but you will see some people mention them like Up to Date and stuff like that. There was a 2011 systematic review that showed no beneficial effect for bulking agents over placebo as far as the improvement in abdominal pain, which again is kind of like one of the main symptoms that we're looking at in IBS specifically. There was a 2012 study in the British Medical Journal that showed slight improvement with psyllium, and 2008 looked at improvement with Bran and showed no effect over placebo. So very, very limited evidence when it comes to the fiber supplements.
Right. So that brings us to the first prescription option for IBS-C, Amitiza, lubiprostone. It's a chloride channel activator that acts locally on the apical membranes of the intestinal epithelial cells to increase fluid secretion. They also increase fecal transit to help move it along. So it's approved, FDA approved for IBS-C in women 18 years and older. It's approved in all adults for
chronic idiopathic constipation.
It hasn't been compared directly to other treatment options. I feel like I saw it relatively frequently compared to some of the other prescription agents. It needs to be taken with food as well.
Yeah. And as far as like the data dealing with Amitiza, there was one 12-week study that showed basically an 18% overall response compared to 10% with placebo. The benefits did kind of persist or even increased as far as the two treatment arms kind of kept getting further apart as far as the effects, but benefits did persist throughout the 52-week follow-up. And in the 2012, the guidelines changed the definition for a response in IBS with constipation studies. So they did a post hoc analysis of that same initial Amitiza study, reviewed the original data, and then were able to show the 24% reduction, or overall response, I should say, and then 13% in placebo. So also the placebo, response went up as well. So that's kind of a high placebo.
It's like they loosened the criteria for.
Yeah. So we just got to get above 20.
I know.
So the other thing is, if you look at the onset of that relief, it did take some patients a month to actually start seeing any kind of benefit from it. And so giving patients sort of that heads up that this is going to take a while to see some relief usually is at least something you should mention to them so they don't just stop taking it because they feel like it's not doing anything.
It's a pretty long time.
It is, yeah. And I will say from my personal experience dealing with this, and I by no means have a lot of experience with this, but a couple of patients that I've worked with this, it's the ones who have way too many side effects with the next few agents we're going to talk about that Amitiza worked really well for, and the patients who, the other agents worked great for, Amitiza was like way too weak or wimpy, whatever you want to call it. So that's kind of how I feel. Even though it's got a moderate recommendation as far as the level of or certainty of evidence from the guidelines, but the data is a lot weaker. In fact, the response that they had was actually like not really what they didn't consider it clinically meaningful in one of the studies. So it's definitely, in my opinion, at least one of the wimpier, these types of meds. Because I think it's not as wimpy as like polyethylene glycol, but it's of all the other prescriptions, it's definitely one of the wimpier ones. Adverse effects too, we have to watch out for some GI issues like nausea, diarrhea. Obviously, anything that's correcting constipation can go too far the other way. And then hypokalemia is something to be aware of as well. Yeah, that's probably the big one.
Yeah. So a couple of other options under the class of guanylate cyclase agonists are Linzess and Trulance. So they increase chloride and bicarbonate secretion into the intestinal lumen, which helps get things moving. Interestingly, in animal studies, they saw some deaths related to dehydration. So they recommend avoiding the use in pediatric patients, and there's also a boxed warning for that. Linzess must be kept in the original container, FYI to the dispensing pharmacist, not to make that easy mistake. And Linzess needs to be taken 30 minutes before breakfast on an empty stomach. With Trulance, doesn't matter. So a little more convenient, can be taken with or without food.
Yeah, I think one of them, the Trulance, is the one that's not pH dependent, I guess. So, but they are the same class, like Cole said, and there are several studies there's 3 studies specifically that have looked at the Trulance, and there's actually 4 randomized control studies that have looked at Linzess. One of them in particular, the Linzess, was comparing the 290 micrograms of Linzess versus placebo, and showed a significant reduction in symptoms with Linzess compared to placebo. So the number needed to treat for the primary outcome was only 6 patients, and statistical difference from placebo was reached by the end of week 1. So much quicker onset of action and relief of symptoms. One study showed a continued benefit at 6 months, where that's kind of unique because most of the IBS studies are much shorter than that. And then there was a study that compared Trulance 3 milligrams to placebo, and again showed a significant reduction in symptoms. Number needed to treat in that study was 9, and again the statistical difference compared to placebo was reached by the end of week 1. So definitely a much quicker response. So the guidelines do have these separated, though, which is actually pretty nice, because before it was kind of just like, well, pick whatever one is covered, because they're both kind of the same. But like I said, the Linzess actually has 4 randomized controlled trials, one of which I think the most recent one that they include was one that was done in China. And so we just have a lot better data, and all of the endpoints that they were looking for as far as the relief of symptoms were improved with Linzess. And so because of that, because of the extra study that they have done with it, the AGA 2022 guidelines recommend Linzess with a high certainty of evidence, and then Trulance with a moderate certainty of evidence.
Nice.
So that's kind of I would say pretty helpful as far as differentiating between which option to go with. So when you have those more, and you'll see this when we look at the algorithm, but when we have more serious cases, more severe cases of IBS with constipation, then probably Linzess would be the best thing to start off with.
Nice. Good to have some guidance.
Yeah.
So the last med for IBS-C is relatively new. I don't know if we've talked about it before.
I can't remember when it came out.
Maybe.
Maybe.
At least a couple years ago. But it's classified as a NHE3, standing for sodium hydrogen exchanger 3. It's branded as Ibsrela.
Ibsrela.
That's a tough one, but you know why it's named that? IBS Rela. Ibsrela.
Yes.
Yes.
That's right.
Terrible thing to pronounce. Generic is tenapanor, but it acts locally to reduce sodium absorption from the small intestine and colon. Reducing sodium absorption leads to increasing intestinal lumen water secretion, and that will accelerate intestinal transit time. So it has a similar box warning for risk of serious dehydration in pediatric patients like Linzess and Trulance. It can also cause diarrhea, I suppose if it works too well. It can also cause dizziness and abdominal distension. So be aware of that.
And it's also got a moderate level of evidence that based on the guideline recommendation. So again, it's definitely an option, and something that I would say if the patient is not doing as well maybe on Linzess, then instead of trying Trulance, which we know is going to be very similar, same class and all that, then maybe this would be a good option to switch them to at that point. Before we move on, though, it's that time of the episode where we give you the super secret password that we came up with 3 seconds before we started recording.
It's time for the word scramble.
And yeah, so the first word is Z. No, okay, so the password for this episode is bowel, B-O-W-E-L. B as in boy.
B as in boy.
To be confused with vowel.
Not to be confused with V as in Victor vowel.
Bowel, B-O-W-E-L, all caps, that's your password. Good luck on your super tough exam.
It might be LWAB.
What?
Could be LWAB.
Oh, because it's a word mix. I got you.
It's a word scramble.
I was like, I believe it is pronounced bowel, but but it could be LWAB. That's definitely a good thought. Thank you, Cole. All right, so IBS diarrhea, move on.
Yes. When you were mentioning those criteria earlier for like IBS with diarrhea, I was like, man, I think I definitely have qualified for that at some point in my life. And it got me thinking about, I don't know if I've told the story on the podcast or not, but I went on a medical mission trip to South Africa when I was a student. It was me as a pharmacy student with a lot of other physician assistants and physician assistant students. One notably was my girlfriend at the time, who's now my wife. So that's pretty much probably why I went. And they tell you when you go to these foreign countries not to drink the water because you'll get traveler's diarrhea. And I did have a prescription for, I don't know, Cipro or something. Can't remember what it was. And then I brought like Loperamide and Pepto-Bismol in case I had any problems, but I didn't drink the water. I was very careful. But we had this, we were kind of roughing it, and I was staying in this hut, and outside the hut was a outhouse, like a hole in the ground with, it also had the shower in there, and there's no running water, so they had a barrel pretty much on top of the outhouse that created water pressure, and it would come through a pipe and then spew out. Interestingly, they did have some sort of heating mechanism. It was like this flash heater that just flashed the water really hot when it came out. High risk for electrocution,
right,
but actually was pretty comfortable.
Nice.
Nobody told me to keep your mouth shut while you're taking a shower, so that you can't get some of that barrel water into your mouth. Long story short,
you got the barrel water.
I got the barrel water and had a just horrible night of
Montezuma
diarrhea.
Came back and got you?
Every 5-10 minutes was going back out to this outhouse filled with bugs in this hole in the ground.
Could you imagine if the way you end that, like not only did you have that experience, but then you also get malaria on top of it?
It was a high possibility.
That's not a good way to end that trip.
So it was a terrible night. I did end up going to the clinic still the next day and participating, but I took a bunch of Loperamide, bunch of Pepto, I took the antibiotics. So the next day, I actually did not go like the whole entire day, but I had this feeling of horrible abdominal pain and urgency the whole entire day. We had to ride 3 hours in a bumpy van across South Africa in dangerous areas. And the whole time, I'm like...
You're just going, forget the danger. I have to get
I was about to tell the driver to stop the van the whole entire time because I thought I was going to have to go out with the zebras in the brush.
Of course. What other choice did you have?
That was probably my worst experience my whole life.
Sounds like the worst.
It was terrible.
I have to go. I'm going to step outside real quick. Hopefully a lion doesn't eat me.
Just telling you what.
Yeah,
would you classify that as painful diarrhea?
I would classify that was not painless diarrhea.
Yeah, it was definitely mixed pain as far as pain goes.
Yeah,
that sounds painful. That sounds awful.
Anyways, I thought everybody would be interested in that.
Yeah, no, that's really good. I appreciate you sharing that. I'm sure. Hopefully no one was eating their breakfast or anything.
When you're teaching, you have to put the content in context.
It's a good tool.
Yeah,
for sure.
It's. So
if you guys are wanting to take notes here, that's the takeaway from this episode about.
You're welcome.
Do not drink the barrel water.
Don't drink the barrel water. Don't open your mouth in the shower.
Yeah, especially
it's not just what you would think is drinking water.
Right. Yeah, I don't really think of the shower water even here as drinking water, but
I don't know. Sometimes I'm really thirsty, and
we got to get you a better. We got to get you a better fridge.
This water's pretty hot, but I'm really thirsty. So.
Just scold your.
I am really bad about staying hydrated, and so sometimes when I think about it, it's like when I'm showering right before bed, and I'm like, I need to hydrate. So it's clean.
That's
that sounds gross.
It's clean.
But there's no ice in it.
No, there's not.
It's not refreshing.
No, it's not.
Anyways, now I'm going to be thinking about that every time I get in a shower. I'm like, this crazy freaking Cole's drinking the water in here. May or may not have soap in his mouth. All right. So the first medication when it comes to IBS with diarrhea being the predominant symptom would be, and this is where the guidelines definitely differ between the two, because the 2020 guidelines say actually don't use this. 2022 AGA says that you could consider it for mild IBS diarrhea. It does give a very low certainty of evidence, but it's still listed. So Loperamide or Imodium AD, as Cole had obviously taken way too high of a dose before he went on his little trip through South Africa.
My walkabout.
So mechanistically, it's going to work directly on intestinal muscles through the opioid receptor. And so this is going to inhibit peristalsis, prolong transit time, reduce fecal volume, increases viscosity, it diminishes the fluid, electrolyte loss, and so working on multiple paths to kind of keep the patient from having that main symptom that they're trying to avoid, being diarrhea. The suggested dosing, and this is the dosing specifically for even acute diarrhea as well, not even just IBS, but having 2 milligrams is kind of like the starting dose, 45 minutes before a meal. You can do that like for regularly scheduled, if you want to have a max dose of 16 milligrams per day, or if it's an acute situation and, you're trying to use this just for temporary relief, 4 milligrams is the loading dose, and then 2 milligrams after each loose stool. Still probably trying to keep it under 16 milligrams per day.
Mm-hmm.
There was a systematic review that showed loperamide being superior to placebo for IBS diarrhea patients, effective at decreasing stool frequency and consistency, not symptoms of bloating or abdominal discomfort, which obviously with the new Rome 4 criteria is an important piece of the puzzle.
Well, I definitely have bloating and abdominal discomfort.
You really can put yourself in.
I can speak very well to
very
this.
well. No, it's impressive for sure. You've had a rough go of it. It sounds like.
Not only that piece, but the other piece is that loperamide has potential for abuse, which I think I may have accidentally done.
Yeah.
Patients.
If anybody knows a good counselor to get hold to,
to get me through my loperamide addiction.
Yeah.
Patients have used over-the-counter loperamide to self-treat symptoms of opioid withdrawal, or to achieve euphoric effects of opioid use, so like potentiating an opioid high. Because of its effects on the opioid receptor.
Yeah. And there's cases of people overdosing and actually passing away from loperamide.
It has a box warning for cases of torsades, arrhythmias, cardiac arrest, death. Yeah. So that was definitely a risk for me that night. Mm-hmm. I could have died from drinking.
You think you took more than 16 milligrams?
I actually probably did not. Like that would be 8 capsules.
Yeah. At the time, you were probably like, this is so much.
I know.
Not realizing that I could probably take 32 milligrams and not, maybe not. Probably. Right. That's probably not true. But
so I doubt that I even took over 16. But I could have, because I was just
You were not counting.
I was not counting. Lots of pep.
Could have been 1, could have been 10.
Could have been. It could have been. It does have some contraindications. So like severe instances like bloody diarrhea with a high fever, don't take loperamide.
Could be C. diff.
Could be C. diff. Could be something serious. And then, of course, like Mike said, can still cause abdominal cramping, constipation, which I think I probably went from diarrhea to constipation.
Exhibit A.
Exhibit A. Nausea, had that.
Mm-hmm.
And QT prolongation.
Did you have that?
Hence the torsades. I could have.
We don't know.
Didn't have a dang EKG with me.
Unbelievable. You go to a medical missions trip, don't even bring an EKG to check yourself in case you get horrible diarrhea.
We did smuggle in lots of bags of drugs, but apart from that, no EKG.
Like medical, approved drugs, guys.
Well, sure.
And in case, could you imagine? That's how Cole lets us know that he's a drug smuggler. That would be fun. We never suspected anything. All right. So another option is Xifaxan, which is an antibiotic that stays in the GI tract. It doesn't get absorbed systemically, so you don't really see this being used outside of things that have to do with the GI system in particular. So it was originally actually designed to reduce hepatic encephalopathy recurrence, and they would add it to lactulose or something. But it's also used now for traveler's diarrhea. So Cole might have been a candidate for this at one point.
Didn't have access to it. And then also IBS with diarrhea, particularly patients who are having a hard time with the bloating from it. So the dosing is a little bit different than you might think as far as the Xifaxan goes. So it's 550 milligrams, but you do it 3 times a day and only for 14 days. So it's like a way of kind of jump starting the patient's relief of symptoms. And you can consider retreating if the patient does have an initial relief or at least improvement in symptoms. If they, at that point, over time start to develop those symptoms, they start getting worse again, you can retreat with another 2-week course of Xifaxan. But it is going to be potentially expensive depending on their insurance. The drug is still very expensive, but as far as insurance coverage and things like that, it just kind of depends. Adverse effects, peripheral edema have been reported with this particular drug. Dizziness, headache, flatulence, some of the other GI stuff that we typically think of. Peripheral edema is one that, obviously be aware of for your cardiac patients and things like that may have other comorbidities. And
The American College of Gastroenterology suggests that they call it the non-absorbable antibiotic, Xifaxan for reduction in global IBS symptoms as well as bloating and non-constipated. They put it in non-constipated IBS patients. So I guess IBS with diarrhea.
Yeah.
So it's probably an easier way to say that. But so yeah, it's definitely a option, although potentially an expensive option, but it is only for 2 weeks. So
interestingly, we manage that in our specialty group.
Yeah.
Xifaxan. Yeah. It's got a pretty good 340B price for those who have access to that.
Yeah.
Another one is Viberzi. Its generic is eloxadiline.
Mm-hmm. Close enough.
Yeah, close enough. But it's a mixed mu opioid receptor agonist, kappa opioid receptor agonist, which acts locally to reduce abdominal pain and diarrhea. It doesn't have constipating adverse effects, which is pretty nice for somebody who's experienced those. Can't be used in patients without a gallbladder. So if they've had a gallbladder removed, it's contraindication. If they are an alcoholic, an active alcoholic, or patients who drink greater than 3 alcoholic drinks per day. It potentially increases risks for pancreatitis, and it has other adverse effects like nausea, abdominal pain, upper respiratory infections. They list constipation, even though they mentioned that it also didn't have that as an adverse effect.
They're just hoping you didn't look at that.
Just hoping you didn't pay close attention. You do want to take it with food, and interestingly, it's a controlled substance because of its action on the opioid receptors.
Now, I know I've told this story before, so if you guys have heard me say this, you're going to hear it again. It's not a lot we can do about that. But when I was working I think I was an intern at the time, but I was working in like a dispensing pharmacy, and this older patient came through, and her Viberzi was not ready, and she was quite upset instantly because she was having a bad day. And I was trying to explain that it wasn't due to be like we couldn't fill it because it was a controlled substance and all that. She's like, it's not a controlled substance. I was like, well, man, it actually is. I know it seems kind of silly that they made it that, but because it's similar to some of the pain meds as far as like what it works on in the body, they made it a controlled substance. And she goes, the top of her lungs goes, it is for my diarrhea. It's not for pain. And I was like, yep, I'm also aware of that. But I just thought that was really funny that she's just got that irate to where she screamed out my diarrhea in the middle of the waiting room.
There's been so many instances that I can recall in retail pharmacy where somebody did scream out at the top of their lungs, a patient, not myself.
That's good.
I really feel for you guys. Fighting the good fight.
I do wonder at what point, like in my bad day, I'd be having where I would actually just start yelling something like that at a random stranger
about your diarrhea.
Yeah, like that's for my diarrhea, just causing a scene.
Or about your Flonase being $10.
Yeah, lots of yelling at a stranger for any reason.
$10 for Flonase.
The southern accents just going crazy because they can't believe that they have to pay some. Flonase is just nasal spray. I can get Afrin right here. Like, it's not the same thing. Anyways, okay. Now you guys know where we work in good old South Carolina. Mm-hmm. Out in the country. Okay. Allocetron is another potential option for diarrhea or IBS with diarrhea. And it's only approved for female patients whose symptoms have lasted for 6 months and who have failed to respond to all other conventional treatment. So this one is works on a serotonin receptor. So it's a 5H3 antagonist, 5HT3. If I could say the abbreviation correctly, that would help. And then adverse effects, and the reason why it's only approved for patients who have failed other treatments, female patients specifically, is that one of the warnings on it is they can cause ischemic colitis and complications of severe constipation, which actually led to its initial withdrawal from the U.S. market. It is still available under like a strict prescribing program. The starting dose is lower than it was previously when it was FDA approved for just distribution. So it's still out there, but it is much harder to get access to, and it's something you should save for last line.
Yep, that's IBSD.
Now, IBS mixed. No, I'm just kidding. We're just going to talk about global symptoms. So this can happen with everybody.
Yes.
Mixed, you just treat whatever one's the predominant factor at that moment.
Right.
So IBS global symptoms.
Yeah, how would you describe global symptoms?
I think it's just one of the pain and discomfort from the abdominal region,
like the non-constipation, the non-diarrhea related adverse effects.
Yeah, right? Usually like just this little pain.
Right.
That is very obviously a part of IBS, but I'd say the treatment of this that's actually recommended in both guidelines is tricyclic antidepressants. So a lot of times, at least before I'd read the guidelines, from 2020 even, I was kind of always assumed, well, antispasmodics would be probably the best thing for that. But there's actually a lot of data around both tertiary amine tricyclics and secondary amine tricyclics. So from a tertiary standpoint, the amitriptyline, doxepin, imipramine, and then from a secondary amine standpoint, we have disipramine and nortriptyline. So these are going to block the reuptake of serotonin, norepinephrine. They're blocking acetylcholine. They're blocking from binding to the muscarinic receptors. They're blocking histamine from binding to histamine receptors, and they definitely have their fair share of side effects. In fact, some of them that are more cardiotoxic, like amitriptyline, they can cause fatal arrhythmias if you take too high of a dose. And so patients, even at a reasonable dose, if they do have like cardiac risk factors, if they're they're over the age of 50, it's probably in the patient's interest to get an EKG if possible prior to them, starting treatment, just to make sure there's not some kind of underlying arrhythmia there. Adverse effects that are very common, orthostasis, and then anticholinergic effects in general. Vivid dreams, weight gain, sedation, and sweating are all, pretty common. The tertiary amines that I mentioned are the ones that are going to be more likely to have those adverse effects. I will say, if you are trying to think about like which of these would you use in a patient, if it's a patient with IBS with constipation, then giving something like amitriptyline, which has probably one of the more higher anticholinergic effects, is probably not going to be the best bet because that's going to induce even further constipation. So you might help with their global symptoms, but the actual constipation itself is going to potentially get worse. And so using one of the secondary amines in that case. If it's a patient with IBS with diarrhea, though, then that's where your boy amitriptyline can come in and hopefully save the day with inducing some of that anticholinergic effect and actually improving the symptom of diarrhea and the global symptoms.
Yeah. Mike mentioned the tertiaries are a little more side effect heavy, secondaries are a little less. So if you had to rank them, amitriptyline is probably has the most side effects. Yeah. Imipramine would be next, then nortriptyline, then disipramine, maybe at the bottom.
Yeah.
They are both, like Mike said, recommended by the ACG and the AGA guidelines. But antispasmodics, in the 2020 ACG guidelines, they recommend against them. So Mike mentioned dicyclamine, bentyl, also hyoscyamine. But the 2022 AGA guidelines say you can use them. They recommend their use, but they give a low certainty of evidence for them as being beneficial. Which, I don't know. If they seem to be effective and they're not dangerous, I guess they can't have side effects. But
I think the 2020 guidelines, I think their argument against it was that if you constantly give these antispasmodics, you could be masking how severe their IBS actually is and masking how well controlled or the need to escalate therapy.
I can see that because I definitely had some patients who would get a buttload, no pun intended, of hyoscyamine and dicyclamine. Yeah. Like a lot of it. A lot.
And I think that's what they were trying to avoid, is just those dicyclamine with all these different refills and, just keeping patients on it long term, because they are supposed to be an acute
it's
thing.
Really a PRN thing for like breakthrough discomfort versus something they take prophylactically to prevent the discomfort, which many people I saw did it that way. Yeah.
So just we'll touch on those two in particular. So hyoscyamine is a very common antispasmodic or anticholinergic as well, as how you would also classify that. The dosing typically is 0.125 milligrams to 0.25 milligrams, taken either orally or sublingually, usually 3 to 4 times a day as needed, as Cole said, not to be scheduled indefinitely. Adverse effects, obviously anticholinergic effects, so blurred vision, dry mouth, constipation, all those things are can potentially occur with any anticholinergic. Tachycardia has been reported, abdominal pain. So definitely not, completely benign, but a lot of times patients can take these without having too many issues as far as adverse effects. Dicyclamine is also antispasmodic, anticholinergic. It's dosed usually 20 milligrams 4 times a day. It's something that we should typically avoid if a patient has ulcerative colitis as well, due to the increased risk of toxic megacolon. And besides the anticholinergic effects, the other adverse effect that kind of stands out to me is that it can induce anxiousness in some patients. So if they have a more, an underlying anxiety disorder or anything like that, then maybe use some caution. It would probably be a good reason why not to use these in some of those patients.
That's interesting.
So
kind of fits the bill with some of the patients who would take a lot of dental that I've seen.
Yeah. And AJ, will you switch over to my screen again real quick? So this is an algorithm that the AGA guideline published along with their actual guideline. And so you can go on the website and get this access to this for free. But it's at the top, kind of run down this algorithm. It says all IBS patients. So you've established they have IBS, moving on. It does talk about, education and resources about like lifestyle modifications. So dealing with stress reduction, exercise, sleep, and then all the different potential dietary modifications that can help. So things we talked about, the low FODMAPs or fiber, things like that. At that point, once you've kind of given the lifestyle and changes in information that they could benefit from just overall, then obviously you want to kind of classify them as either being IBS with constipation or IBS with diarrhea, or a mixture, obviously. If it's constipation and it's more of a mild form, for the constipation itself, then you could get away, or at least with a trial of Miralax, polyethylene glycol, that we talked about at the beginning. And at this point, if they are having the global symptoms, the abdominal pain in particular, then you can consider the antispasmodics, and also hyoscyamine, the dicyclamine, and then also peppermint oil was one that even the 2020 guidelines did recommend as an option. So on the IBS with diarrhea side, if it's mild for the diarrhea itself, you can use loperamide. They also mentioned potentially using bile acid sequestrants, so like Welchol, but they didn't really go into that in detail in the guideline itself. They just kind of threw it on the algorithm. So it's kind of interesting. And then same thing with the abdominal pain here. You can use the antispasmodics, peppermint oil would be a good option for those global symptoms at that point. So that's mild. Now, if they have more of a moderate presentation or more severe, where they're actually looking at patients that need to escalate therapy. On the constipation side, we have our secretagogues, so our Linzess, Amitiza, Trulance, all that good stuff, Isbrella. And remember, the Linzess is the one that has the highest level of evidence as far as the newest guideline goes. So that would be one that I'd say probably would start off with. And then, like I had said earlier, if the patient is having issues with side effects, specifically like if the Linzess is causing just really bad diarrhea, really bad abdominal issues, then dropping it down to Amitiza, I find, at least in my very limited experience, tends to be a good option because it's a wimpier drug in the first place. If the Linzess was working or not necessarily fixing their symptoms, or at least completely putting their symptoms in remission, but they weren't having the side effects to it, at that point, if you are going to switch, Trulance or the Isbrella would probably be the better options at that point. And then one that we didn't mention that it is on the guideline is the Tegaserod, which is one that we didn't really cover. It's been removed off the market officially, I think in November maybe last year, 2022. And so the guidelines were published before that happened, and so there's a very, very limited supply left in the U.S. that is, once it's used up, they're not going to make any more. And then on the diarrhea side, again, if it's more moderate to severe, we're looking at Xifaxan, using a low dose tricyclic as well, like the amitriptyline, dizipramine, one of the medications that can induce constipation, basically those anticholinergic effects. And then Viberzi is another option at that level. And then last, you would try the Alisatron. It's kind of for your female patients that are able to tolerate that without worrying about the ischemic colitis and those major potential risks. And then from there, if it's still not enough, then you can add or switch to a low dose TCA if they're not already on that. There's some very, very limited and not very good evidence with SNRIs. There's something called brain gut behavior therapy that can be done. So like CBT, hypnosis, things like that you can use to improve brain gut behavior therapy. So that's kind of like their last line of defense, so to speak.
So
hopefully the medication.
An interesting one.
Mindfulness about your GI
I'm
issues.
going to hypnotize you into someone who doesn't have diarrhea.
Dude, I want to be hypnotized so bad.
I'm going to hypnotize your gut bacteria.
There's 0 chance I'm going to get hypnotized. I would, if someone's waving at...
You think it's legit, some of those videos?
I think some people can be, I don't know. Yeah. I don't think everybody can be.
They're just prone.
There's no way my brain would even let me be in the mindset of like, oh, I'm just going to relax. And
I know.
Like, I would be making fun of it the entire time.
Even if I actively tried, like, I recognize that the only way for this to happen would be for me to just accept it and be...
And my brain's like, don't do that. Yeah. Don't be a wuss, dude. don't give in. Just sit on the couch with my eyes wide open.
I imagine they screen those people before they do, like, they kind of have an idea who would be.
They're probably, you mean like the magic shows and stuff?
Like the ones that are actually like
balk like a chicken and stupid stuff. Those I feel like those have to be plants or just very easily.
I'm sure
if those are real people that are that easy to manipulate with trickery.
I'm sure there are many that are plants.
We could have an army.
You would think that it would be much more widely known if all of them were just totally faked. You know what I mean?
$50, I'll keep the secret.
Dude, I would tell everybody. If I learned how to do hypnosis on people and I actually was like, I wouldn't do anything else all day long. Just like, hey, just doing it to the dog. He thinks he's a cat now. It'd be hilarious. Anyways, so that's our time for today. I hope that was helpful. And AJ, did we miss anything? Anything else we got to make sure we touch on before we get out of here?
We had a question from YouTube. We're streaming. They asked, can we evaluate the efficacy of DocuState sodium?
So wait, is that YouTube channel that commented? Is their name SIP2D6?
Yeah, you read that correct.
That is it's
fantastic.
That's the most hardcore YouTube channel. There's no numbers after it. It's just 2D6. They got the first.
They got it.
That's incredible.
I wonder what other SIPs are out there that I could snag.
I don't know.
Get 3 or 4 tonight.
Don't you do it.
TC19? That might be mistaken for some COVID-related.
Yeah, you get flagged on YouTube immediately. Yeah. So as far as DocuState goes, stool softener, just to address that really quick, I don't have the literature in front of me as far as the IBS specifically, but the way I kind of think of that is from a stool softener standpoint is that whole, that ancient wise saying that says all mush, no push. From a constipation standpoint, you don't really get that peristaltic activity like you would from an osmotic or a stimulant laxative. And so typically, especially for a chronic condition like IBS with constipation, I would say it's probably not the best option. If you're in a pinch and you don't have a lot of different options around you and that's available, then sure, I'm sure it'd be okay for an acute situation. I just don't think it's going to be all that effective chronically.
I imagine it'd be tossed in with kind of when we were talking about the bulk forming agents. It probably wouldn't get a level of recommendation from the guidelines. And there's questions as to how effective it is in general.
Yeah. So there you go. That's my recommendation based on literally zero research. That's my thoughts on it. So
good thought.
Thanks for asking the question. I appreciate it.
So 2D6.
2D6.
Check him out on YouTube.
Check him out. Yeah, that's an awesome name. I wonder how'd you get that cool name, man? All right. So thank you guys so much. I hope that was helpful. Sorry we were a little off topic with our nonsense today, but every once in a while. If you have any questions for us, make sure you email us. Our emails will be in the show notes. You can send us a text. You can reach us on any of the social media platforms. And if you are a free CE Unlimited member or a Gold or Platinum member, make sure that you go to their website, freece.com, and take the post-activity test. Get your 1 hour credit for your South Carolina pharmacist licensing renewals coming up.
It's time.
It is. I should really start looking at doing that.
I probably should too.
Yeah. So make sure you claim your credit, get your license renewed, keep your job. It's important. And we'll catch you guys in the next episode. Have a good night.